Hello, and welcome to MedNews Week Keynote Conference, where our goal is to bring you the most cutting-edge information from medicine's global leaders. I'm Gayatri Menon, and I will be your host for today. Before we begin, I want to first acknowledge the great team that helps to make these events a reality. Our founders are two internationally recognized researchers, Drs. Jan Leifman and Chandler Park, who is also the president of Kentucky ASCO. Our chairs include Drs. Park and Leifman. Our associate directors include Madhuri Balasubramanian, Muskan Joshi, and Gayatri Menon. Our managers include Alexandra Vanderkeef, William Wilkerson, and Ahmed Aziz. Our educational committee includes Sean Jacobies, Choria Harshal, Rida Khan, Harshita, Helena Koloma, Saumya Nader, Rabab Hunaid, and Imad bin Zahid. We also want to thank our partners, a global leader in medical educational content, and the National Society of High School Scholars, an honor society founded by the Class Nobel of the Nobel Prize family. The moderator for today's event is Jenna Ghazal. Now, to introduce our keynote speaker, Dr. Kathryn Lurain. Dr. Lurain is the clinical director of the HIV and AIDS Malignancy branch at the National Cancer Institute. She is an internationally recognized leader, physician, and researcher in HIV and AIDS malignancy. She was also the principal investigator of multiple phase 1 and 2 clinical trials using immunotherapies to treat HIV-Associated lymphomas and Kaposi sarcoma. She is also the recipient of several prestigious awards, such as NCI Director's Award for Making an Impact and the Clinical Excellence Award at the Center for Cancer Research at NCI, among many others. She is also a renowned speaker and panelist who has delivered over 20 keynote presentations globally. A passionate and dedicated physician who has mentored multiple students in various stages of training, Dr. Lurain has truly done it all. With that, it is my pleasure to welcome Dr. Lurain. Doctor, the floor is now yours.
Thank you for that very kind introduction. I appreciate it. And it's a real pleasure to be here with all of you today. I'm very honored. I'm going to share my slides now. And as already mentioned, yes, I am the clinical director of the HIV and AIDS malignancy branch at the National Cancer Institute. So I spend all of my time caring for people with HIV and cancer and conducting research in this area. And so I'm very passionate about it and really excited to share that with all of you today. And the title of my talk is HIV-Associated Cancer is a Viral Story, since much of my research and cancer in people with HIV is closely tied to oncogenic viruses. These are my disclosures. I receive research funding through my institution for my research from these entities. And why are we talking about HIV and cancer today? Well, these two have been linked since the very beginning of the HIV pandemic in the early 1980s. We often think about infectious disease and HIV, but it was cases of Kaposi sarcoma in previously healthy young men who had sex with men that was one of the first harbingers of the epidemic. Shortly thereafter, it was cases of primary central nervous system lymphoma as well that were other harbingers of the epidemic. And so HIV and cancer have been linked for a long time. And in fact, many of the breakthroughs in cancer have come from some of the breakthroughs that were actually developed originally for HIV, such as CAR T-cell therapy. And what do I mean by when we talk about HIV and people cancer and people living with HIV? Well, there tend to be two terms that people use, AIDS defining and non-AIDS defining, that are really historical terms. And us in the field, we are trying to get away from these two terms and really talk about the cancers that we really mean, and those defined by being associated with higher degrees of immunosuppression and occurring at lower CD4 counts, and those that occur at much less immunosuppression and higher CD4 counts. Although these are truly generalizations, and these cancers can occur across the spectrum of CD4 counts. But generally, those that occur at lower CD4 counts include Kaposi sarcoma and aggressive Bcell non-Hodgkin lymphomas. And these are very closely linked to oncogenic viruses, those being Epstein-Barr virus or EBV, or Kaposi sarcoma herpes virus or KSHV, which some of you may know as HHV8 or human herpes virus 8. Now, those cancers that occur at higher CD4 count, there's a wider range of them, and they're also associated generally with oncogenic viruses. Human papillomavirus causes anogenital cancers, cervical cancer, as well as head and neck cancers. Hepatocellular carcinoma or liver cancer is associated with hepatitis B and C viruses. Hodgkin lymphoma is associated with Epstein-Barr virus to almost 100% of the time in people with HIV. And non-melanoma skin cancers can be caused by Merkel cell polyomavirus. There's the important exception of lung cancer that is not associated with oncogenic viruses. But these are really the cancers that we're talking about when we're talking about cancer in people living with HIV. These occur at much higher rates than the general population. And that's not to say, however, that people with HIV cannot have incidental cancers that are common in the general population, like breast cancer, prostate cancer, and colon cancer. However, those are not known to occur at higher rates in people living with HIV. And the good news is that the new cases of HIV diagnoses have been declining in the United States over a long period of time now. You can ignore that 2020 big dip. That's probably an anomaly related to the COVID-19 pandemic. But in general, new diagnoses of HIV have been declining for some time, thanks to significant public health efforts. But there are over 1 million people living with HIV in the United States, and there are still 20,000 deaths every year related to HIV. And unfortunately, that's because only about 2/3 of the people living with HIV in the United States are on antiretroviral therapy, and their HIV is virally suppressed. And this is important not only for the health of patients who are living with HIV, but it's also an important tool for prevention of new diagnoses, because we know now that people living with HIV who are on antiretroviral therapy and have undetectable HIV viral loads cannot transmit HIV to other people. And this is the geographic prevalence of HIV in the United States. This is from 2021. And you can truly see here that the burden of HIV is not equal among the different areas of the United States, with the highest proportion of people living with HIV in the southeastern United States. They're represented in the darkest red. This is also where the highest number of new diagnoses of HIV occur, and where the highest number of people who are not virally suppressed are living. And unfortunately, like many of the chronic illnesses in the United States and around the world, there are racial and ethnic burdens that are not shared equally among our population of patients. So among Black men, they are 5.6 times more likely than white men to be diagnosed with HIV. And Hispanic or Latinx men are almost 3 times as likely to be diagnosed with HIV. And Black women are more than 16 times more likely than white women to be diagnosed with HIV, and Hispanic women are more than 4 times likely than white women to be diagnosed with HIV. But thanks to the incredible efforts of biomedicine over the last several decades, led by the National Institutes of Health, are the incredible advances in antiretroviral therapy and HIV treatment. And so therefore, there are an actual increasing number of people living with HIV around the world because people are living longer. And you can see over in the graph on the left, the proportion of people who are older in the yellow and orange is increasing over time as the population of people with HIV is aging. And if you look over on the right, this is a model out to the year 2030 from my colleagues in the NCI, who mapped how the HIV epidemic, the age will change over time. And you can see in the light green and the white, over time is increasing, and that's the people over 45 and over 65. And so the population of people with HIV is aging. And we know that cancer is a disease of older people. And so all of this is changing the epidemiology of cancer in people living with HIV. Now, If you look here, this is again from that same paper, modeling out to 2030, looking at AIDS defining versus non-AIDS defining. I know I said we weren't going to be using those terms, but this is an older paper. And so generally you can think of AIDS defining as those that occur at lower CD4 counts, and non-AIDS defining as those that occur at higher CD4 counts. You can see over time in the light green and the dark green, those cancers associated with less immunosuppression, so generally people who are going to be on antiretroviral therapy, are increasing as a proportion of the number of cancers that are being diagnosed in people with HIV. So those that occur at low CD4 counts, like Kaposi sarcoma, and certain types of non-Hodgkin lymphoma, are declining. And the proportion of lung cancer, anal cancer, and liver cancer is increasing over time. It's also known that incidental cancers are increasing over time as well in people living with HIV as they age. And all of this is to say, though, when you look, remember I showed you the map of the United States, where the southeastern United States has a high proportion of people living with HIV that is not controlled, and there's more new diagnoses. These same statistics are not bearing out exactly the same. We know that Kaposi sarcoma is stable to increasing in certain populations, so particularly among men who have sex with men, and Black transgender women in the southeastern United States, those numbers are stable. And so the burden of HIV and cancer is definitely not shared equally among all of our population of people here in the US. And unfortunately, despite the major advances in antiretroviral therapy over time that has turned HIV to a chronic illness, people living with HIV and cancer still have higher overall mortality than the general population. And this is due to several factors. And you can see here on this graph from my colleague at the NCI previously, Anna Coghill, that for all of these cancers listed along the bottom, there's two columns, one in people with HIV and one without, and you can see the columns and the deaths are much higher for each of these different types of cancers across the board, those that are associated with HIV and those that are not associated with HIV. So people with HIV, unfortunately, tend to present with more aggressive cancer. Their tumors have more negative prognostic markers. They tend to occur at higher, present with a more advanced stage cancer. Unfortunately, people with HIV can also present with more than one cancer at a time. I have many patients who have lymphoma and have a concurrent diagnosis of anal cancer or a concurrent diagnosis of Kaposi sarcoma, and it makes it more difficult to treat both cancers. In addition, unfortunately, even currently in this day and age, people with HIV do not receive standard cancer treatment. And this means that they may receive less aggressive therapy, they may not receive novel therapies or newer therapies, or they may receive no cancer therapy at all. And we do also know that they have less access to palliative care services. And one of the reasons why people with HIV don't have access to novel therapies is because they are excluded from cancer clinical trials the majority of the time. And so they don't have access to those trials, but also then when agents are approved, oncologists may be hesitant to use those novel agents because there's no data supporting their use in people with HIV. And unfortunately, like many chronic diseases, there is definitely stigma against people with HIV, as well as sexual and gender minorities who make up a large proportion of the people living with HIV. There's also structural racism in our healthcare system that affects the large proportion of Black and Hispanic patients who have HIV. And so there's just a numerous number of reasons that people with HIV do not have the same mortality from cancer as people with HIV when we're talking about real-world evidence. So how can we improve outcomes for people with HIV and cancer? Well, number one, really takes a multidisciplinary and gender inclusive care environment to care for people with HIV. So it's not just oncologists. Oncologists need to work very closely with HIV specialists, pharmacists, and hopefully pharmacists who have knowledge of both oncology drugs as well as HIV drugs, nurses, social workers, and patient navigators. Our team at the National Cancer Institute in the HIV and AIDS Malignancy branch is made up of all of these types of practitioners, in addition to occupational therapists and counselors. And so I think oncologists shouldn't think that they need to do it all themselves. It really requires you working with a large group of people together to care for patients. In addition, particularly in patients who have low CD4 counts, it's important to screen for and prescribe prophylaxis against opportunistic infections. And oncologists shouldn't feel that they need to do this alone. Again, this should be in concert with HIV specialists. But I think it's very important that oncologists be aware of the competing symptoms and treatments that may be required in addition to cancer therapy that need analysis. In addition, as I've mentioned before, people living with HIV, there's no evidence that they shouldn't receive standard cancer therapy at standard doses where indicated. The guidance from ASCO, the American Society of Clinical Oncology, recommends that patients receive standard therapy, not adjusted for the fact that they have HIV, and only adjusted for any types of comorbidities or reasons that you would adjust someone's cancer therapy in someone who didn't have HIV, like their performance status or their organ dysfunction, not simply because they have HIV. So now I'll talk about why do people with HIV get cancer more frequently. And as many of you may know, people with HIV have lower CD4 counts, and CD4 T-cell lymphopenia is an important cause of the reason why people have increased cancer risk. But that's not the only reason. Chronic viral stimulation, either from HIV itself or other oncogenic viruses like EBV, KSHV, or HPV, they chronically stimulate the CD8 T cells, and that chronic antigen stimulation leads to chronic activation of T cells. And over time, this can lead to decreased cytokine production and decreased cytotoxic response. So these T cells can't participate in killing of oncogenic cells infected with oncogenic viruses or in immunosurveillance for cancer cells. And over time, this chronic T cell activation leads to upregulation of immune checkpoint molecules like PD-1 or CTLA-4 on the outside of T cells, and eventually can cause T cell exhaustion. And so it isn't just about the CD4 count. There's major immune dysregulation that occurs even in people who have well-controlled HIV on long-term antiretroviral therapy. These effects are reversed significantly by antiretroviral therapy, but not completely. And we do know that people with HIV, even with controlled HIV and normal CD4 counts, have increased expression of PD-1 on their CD8 T cells. And one of the reasons why lymphoma is so important and many different types are at increased incidence in people with HIV is because of the effects of HIV and the oncogenic viruses EBV and KSHV on B cells. So again, this chronic antigenemia from HIV or these oncogenic viruses causes polyclonal B cell hyperactivity. And these activated B cells give off increased gamma globulins, increased cytokines, which increases proliferation of B cells and increases the risk of clonogenicity. In addition, the viral homologs of these some of these oncogenic viruses, so for instance, KSHV makes its own viral cyclin and can cause infected cells to enter the cell cycle growth inappropriately. So these viruses also have ways to keep cells alive and growing as a way to maintain infection, and this causes sort of decreased immune surveillance among infected B cells as well. And unfortunately, despite the activation of B cells and the increased clonogenicity and proliferation, these B cells actually are not very immune responsive. So they're skewed and they are not participating appropriately in maintaining proper antibody responses necessarily to HIV, EBV, or KSHV. So, and these side effects are definite of HIV are not fully reversed by antiretroviral therapy either. So now let's talk a little bit about lymphoma as sort of a case study for how this, how all of these different aspects of HIV may affect patients. And so lymphoma and its subtypes, which are many that occur in people with HIV, is the most common group of cancers that affect people living with HIV in the United States. And among internationally, it's also number 1 or 2 in most countries where the HIV epidemic is highest. The incidence is 10 to 20 times more common than the general population, depending on which subtype you're talking about. And antiretroviral therapy, similar to other types of cancer, has decreased the risk of certain subtypes of lymphoma. And this is one of my patients that I diagnosed with HIV and diffuse large B-cell lymphoma, who's now cured. So the subtypes of lymphoma that we're generally talking about when we're talking about HIV-associated forms are diffuse large B-cell lymphoma, which is the most common, just like in the general population. But Burkitt lymphoma is the second most common, which tends to be fairly rare in the general population, at least in the United States. And then there are these other rare subtypes that are really only occurring in people with HIV, and those are primary effusion lymphoma, plasmablastic lymphoma, and primary central nervous system lymphoma. So this is another one of my patients here who was diagnosed with primary central nervous system lymphoma, who was also cured. And finally, Hodgkin lymphoma is also increased in people with HIV, as well as, I haven't mentioned here, but T-cell lymphomas are also increased in people with HIV, although there's far fewer data documenting that given the rarity of T-cell lymphomas. But unfortunately, people with HIV also present with more frequent high-risk features when they present with lymphoma. So patients tend to have more central nervous system involvement or relapse in the CNS. They tend to present with more advanced stage disease or more extranodal disease. And their tumors tend to have more poor prognostic factors such as MYC translocation or MUM1 or IRF4 overexpression. And we do know that EBV and KSHV positivity of the tumors tends to portend a poor prognosis as well. And so this is very similar to other types of cancers. We know that many of the lymphomas are associated with very advanced HIV and immunosuppression have declined over time. So if you look at primary CNS lymphoma in the green here, which is a cancer that is associated with the lowest CD4 counts, usually less than 100. CD4 cells, that has declined over time as a proportion of total diagnoses of lymphoma, as well as diffuse large B-cell lymphoma, which tends to occur at lower CD4 counts. Whereas Burkitt lymphoma in the purple and Hodgkin lymphoma in the dark blue at the bottom, those have increased as a proportion of the total types of lymphoma over time. So ART has also changed the epidemiology of lymphoma overall. And lymphomas are tied very closely in people with HIV with oncogenic viruses. In general, in the general population, Burkitt lymphoma is not in the United States, when it's a sporadic subtype, is not associated with EBV at all. But in people with HIV, it's associated 30 to 60% of the time. And it's 100% of the time in Hodgkin lymphoma, which is also uncommon in the general population. Primary central nervous system lymphoma is associated with EBV 100% of the time in people with HIV. And then primary effusion lymphoma, or PEL, is caused by KSHV. And so part of the definition of PEL is that it's positive for KSHV. One of the reasons why I'm so interested in primary effusion lymphoma is that it also can be co-infected with Epstein-Barr virus or EBV about 80% of the time. And so it's a dually herpes-infected virus lymphoma. And then you can see here along the bottom, those lymphoma subtypes that are generally associated with preserved CD4 counts, and they generally have a better prognosis. And those that are associated with lower CD4 counts generally have a worse prognosis. I do think that there's probably a lot of underappreciation for an improvement in the outcomes of many of these types of lymphoma. A lot of the data that we have are from the early days of the epidemic and before very effective combination antiretroviral therapy. And so I do think that perhaps some of these lymphomas that are associated with a worse prognosis, a lot of their prognoses have actually improved over time. And we certainly have seen this for diffuse large B-cell lymphoma. So this is a study from Stefan Barta and the AIDS Malignancy Consortium, who, when they looked at their clinical trials over the pre-ART area to the current very effective ART era, which is represented in the orange on these two graphs here. They split their data by looking at patients who had CD4 cells less than 50 and those above 50. And they showed that over time, diffuse large B-cell lymphoma prognosis has improved, particularly for people who have quite low CD4 counts. And certainly the ART has definitely improved outcomes, but also our supportive care and how aggressive and our ability to actually treat patients who have low CD4 counts has improved over time. Another important aspect of this paper was that when they looked at what were the prognostic factors that affected outcomes, HIV-related factors were not prognostic. So people's HIV viral loads and their CD4 counts were not prognostic when they were on effective ART in the modern era. It was in fact cancer-related factors that affected outcomes. So stage of presentation, tumor-related factors like MYC translocation and such. So I think it's very important that, again, to hammer down on the fact that we shouldn't be making treatment decisions for patients based upon HIV-related factors. It's truly cancer-related and other patient-related factors that we should be using when deciding on therapy. And it's very important to note that for several different types of lymphoma, HIV status does not affect outcome when comparing patients with the general population. And so here are two studies, one from colleagues in Europe looking at overall survival in Hodgkin lymphoma by HIV status in patients who received standard ABVD for their Hodgkin lymphoma, where HIV status did not make a difference. And over on the right is a study from my colleagues at the NCI looking at event-free survival in Burkitt lymphoma in patients who were treated with EPOCH-R, another now standard regimen for Burkitt lymphoma. And again, HIV made no difference. I think the important caveat here is that these patients were treated aggressively with the same therapy as their immunocompetent counterparts. And so patients, I think, when we think about patients who have very low CD4 counts and are getting rare subtypes of lymphoma, we don't have great data about their outcomes, but we know for at least several different types of lymphoma that occur at higher CD4 counts, when patients receive standard therapy, they do just as well. And this was borne out again, this was just published last month in Lancet Hematology from my colleague Paul Rubenstein and the AIDS Malignancy Consortium, looking at the novel regimen of brentuximab vedotin, an antibody drug conjugate, with AVD, so part of the standard regimen for Hodgkin lymphoma. And this was in people living with HIV who had either advanced stage 2 or stage 3 or 4 Hodgkin lymphoma. And these are the 2-year overall survival and progression-free survival, which are very similar to what was seen in this study in the general population. Pardon me. We also saw that generally, when we give chemotherapy, we expect that patients' CD4 counts will drop. But with this regimen, we saw that CD4 counts and CD8 counts increased over time. And that was impressive. We generally are very concerned about dropping CD4 counts and increasing risk for opportunistic infections with people with HIV. And so I think that this regimen overall is now probably the standard of care for people with HIV and Hodgkin lymphoma. And I'll talk about a small trial that I published with my colleagues in the HIV and AIDS malignancy branch in primary CNS lymphoma. Now, patients with primary CNS lymphoma, they have the lowest of the low CD4 counts, and they tend to have significant other opportunistic infections that occur at the same time that they have their lymphoma. So the median CD4 count in this trial was 16 cells per microliter, which is incredibly low. There were also 3 of the participants who had concurrent CNS infections at the time that they had CNS lymphoma, and the other participants, all of them had a variety of other opportunistic infections. And when we did mini mental status examinations at the beginning of treatment, these participants, who were all quite young, had median scores of 22, which is consistent with mild dementia. And when we gave them methotrexate and rituximab in addition to antiretroviral therapy, the median overall survival was not reached. And our 60-month overall survival was 67%. So 2/3 of these patients, when they were given methotrexate and rituximab, which is standard therapy for CNS lymphoma, patients did very well. And we did neurocognitive testing at the end of treatment, and there was improvement in almost all domains of cognition in our participants. And so I bring up this small trial because it really is possible, I think, to treat patients who have significant immunosuppression and HIV-related complications with curative intent chemotherapy. And if we're talking about novel therapies that people with HIV have not had access to over the last decade, immunotherapy and anti-PD-1 agents are right at the top of the list. Anti-PD-1 agents are approved by the U.S. Food and Drug Administration for many HIV-associated cancers. You can see them listed there. And unfortunately, for all of these approved indications, people with HIV, despite the fact that they were at higher risk for all of these cancers, were excluded from these clinical trials. I'm very happy to report that there was just a clinical trial that was reported at ASCO this summer in frontline Hodgkin lymphoma treatment. It combined nivolumab, the anti-PD-1 agent, with AVD, so the combination chemotherapy, and they randomized those patients to be treated with Nivo AVD or standard brentuximab AVD, which is already FDA approved. And that study included people living with HIV, and they did treat patients with nivolumab AVD on that trial. And so, the outcomes were, they have not reported the outcomes for people with HIV specifically yet, but they did not see any new safety signals in those patients. But there has been a reluctance among oncologists to use checkpoint inhibitors in people living with HIV. There has been some safety concern. Would there be an increase in immune adverse events? Could there be reactivation of concurrent infections such as TB or HBV? The activity, would there be any response to PD-1 inhibitors in patients who have low CD4 counts? And is there a potential for HIV reactivation when people are given anti-PD-1 agents? So this trial was conducted using pembrolizumab, an anti-PD-1 agent, through the Cancer Immunotherapy Trials Network. We published these data back in 2019 when Tom Aldrich was the principal investigator of this multi-center trial. I took over as the principal investigator a few years ago. But when the first 3 cohorts enrolled on this trial were enrolled on safety cohorts according to CD4 count. In these 3 cohorts, it was a CD4 count 100 to 200, 200 to 350, or greater than 350. And what we found was that there was no increase in immune adverse events in these patients. All patients did have to have controlled HIV to enter. They had to have been on antiretroviral therapy for at least 3 months, and we enrolled a heterogeneous group of advanced cancers. If you look at the line graph on the top, you can see that particularly in patients who had low CD4 counts, as represented in the gray and orange, their CD4 counts increased over time with pembrolizumab. And that's one of the big benefits of using anti-PD-1 therapy in people living with HIV, is that it is T-cell sparing. And so you can have people either maintain their CD4 counts or have an increase in their CD4 counts and decrease their risk of opportunistic infections. In regard to HIV, almost everyone had undetectable HIV in their peripheral blood at the beginning of trial. However, in the bottom line graph there, you can see in patients who had some detectable HIV, at least at some point during treatment, no one's HIV viral load went above 300 copies per milliliter, which is basically still very controlled. And then we also saw that there was some benefit in a variety of different types of cancers. Some you might expect, like lung cancer, but also some we did not know about before, such as Kaposi sarcoma. And then diffuse large B-cell lymphoma was somewhat surprising, since studies in the general population have shown that non-Hodgkin lymphoma single-agent checkpoint inhibitors have not been very effective. However, many of those patients do not have oncogenic viruses or EBV driving their lymphoma. And so I think a lot of my work focuses on the fact that there may be reason to think that oncogenic viruses driving lymphoma may actually be more susceptible to anti-PD-1 agents than those same cancers when not driven by oncogenic viruses. And this was one of my patients that we treated at NCI who had primary effusion lymphoma. You can see in his PET scan there on the left, he had, this is a young veteran in his early 30s who had a very significant burden of lymphoma in his abdomen, who had an almost complete response to therapy with single agent pembrolizumab. We will be presenting the results of the 4th cohort of this study at the European Society of Medical Oncology in October. That cohort is the group of patients who had Kaposi sarcoma, and we lowered the CD4 count threshold for that cohort to 50. And so we treated a wide range of CD4 counts, and we're very excited to present the results at ESMO later this year. And the lack of increase in immune adverse events was also recapitulated in a very large multi-center international retrospective trial that was published earlier this year by my colleague Talal Al-Zarif from Dana-Farber. He looked at almost 400 people living with HIV retrospectively from many different institutions, and found that there was a 20% immune adverse event rate in this population of patients, which is very similar to what you might expect in the general population. And in fact, there was a lower rate of immune-mediated adverse events in patients who had CD4 counts less than 200. They also looked at a matched cohort of people with and without HIV who had metastatic non-small cell lung cancer, they had the exact same rate of immune-mediated AEs, as well as progression-free survival with treatment with PD-1 blockade. And so I think really the evidence is not showing any increase in immune adverse events from what we've seen in prospective as well as retrospective trials now, and that there is activity in cancers in people living with HIV with these agents. And this is a retrospective study across several trials that we did in our group at the NCI. We compared CD4 counts and immune adverse events from 3 different clinical trials, one from the pembrolizumab trial that I just mentioned, as well as a trial from Europe using durvalumab in people living with HIV and heterogeneous group of cancers, as well as another checkpoint inhibitor in a trial from the NCI in HIV negative participants who had HPV-related cancers. And what we wanted to see was whether there was a difference in immune AEs, which we did not find among people with and without HIV. And we also found that there was no difference in baseline CD4 counts in those enrolled by their HIV status. And I think this goes to show that patients who have metastatic cancer, who've had prior treatment, they tend to have low CD4 counts, despite the fact whether they do or do not have HIV. People with cancer tend to have low CD4 counts. And so really, it goes to the heart of the fact that people living with HIV should not be excluded from immunotherapy trials. There's really no evidence to do that. All of this evidence so far has shown that people living with HIV are not at an increased risk of safety events, and that they can have very similar response rates to those without HIV. And I truly hope that the trend that we saw with the Nivo AVD, brentuximab AVD trial in Hodgkin's continues to be borne out, and that more and more trials in concordance with ASCO, FDA, as well as NCI guidance continue to enroll people living with HIV. And I'll conclude today just by talking about how I think about treating people with HIV and cancer. And I think this is something that I do all the time, and I find that oncologists, I get a lot of phone calls where people are very daunted about the fact that there's many medical comorbidities that may be occurring in people with HIV and cancer, and what they should do about cancer therapy. And so this is how I tend to think about it. And I think about cancer-related, and then I think about HIV-related factors. If I start with the cancer-related factors here, so thinking about the pathogenesis of the cancer is helpful to me. So in what clinical context did this cancer occur? So if somebody was diagnosed with HIV at the same time that they presented with Kaposi sarcoma and a low CD4 count, that's very different than if someone has recurrent Kaposi sarcoma and has had well-controlled HIV for a long period of time. If cancer occurs at a low CD4 count and uncontrolled HIV, I know that I'll have the benefit of immune reconstitution with ART to help with cancer control, whereas where I will not have that benefit for the patient who has already been on antiretroviral therapy for a long period of time. I also always think about whether there's a need to investigate for additional cancers, particularly in patients who have low CD4 counts, like those patients who had primary central nervous system lymphoma. Many of them had second cancer, so anal cancer, Kaposi sarcoma, and really thinking about whether all of the symptoms that you are attributing to the one cancer, well, is there a reason to think that there could be an additional cancer causing some of those symptoms? Just like any patient who has cancer, one of my first thoughts is there a clinical trial available? So more and more clinical trials are including people with HIV. There's also the AIDS Malignancy Consortium, which enrolls, it is an organization that has trials specifically for people with HIV. They have lymphoma trials, Kaposi sarcoma trials. They're starting to have some more solid tumor trials, hopefully in the future. And then you can also think about our branch, which also we have a variety of HIV-focused trials for people with Kaposi sarcoma, lymphoma, and solid tumors. And also there are some data that are specific for certain cancer regimens in people with HIV. For instance, I mentioned Hodgkin lymphoma. There's now excellent data for using brentuximab vedotin with AVD in people living with HIV specifically. And so that might be your choice over ABVD, since there is that specific data. Most of the time there's not, but it really is in lymphomas where there is some more specific data for people with HIV. If there's no trial or any HIV-specific data, I will offer standard full-dose cancer therapy as appropriate for the cancer subtype. I do not take CD4 count into account, particularly when you're giving curative intent cancer therapy. You should not be thinking about CD4 count or uncontrolled HIV. You should be treating patients' cancer aggressively, and particularly when lymphoma is the case, there may be other concurrent opportunistic infections, and if it's a low CD4 count. And I truly think that if you have a cancer that's very responsive to chemotherapy, for instance, like a lot of aggressive lymphomas, patients can be extremely ill and you can still give them aggressive therapy with curative intent, something that I do very frequently. And then finally, does the specific cancer therapy raise concern for certain opportunistic infections? So if you're going to be giving large amounts of combination chemotherapy along with rituximab, you probably are going to need to think about prophylaxis for pneumocystis pneumonia, potentially other types of opportunistic infections that even though their CD4 count might be 400 now, it may drop below 200 very soon. And you need to think about whether that's going to be a risk for your patient. When I think about HIV-related factors, I think about whether the patient is receiving ART already. And if they're not, then I work with my HIV specialist to design a regimen, hopefully avoiding regimens that contain a booster to boost the levels of certain of the antiretroviral therapies. So those being cobicostat and ritonavir, those are CYP3A4 inhibitors and will cause significant interaction with many cancer therapies. Luckily, monoclonal antibodies definitely don't have the same interactions. And it's one of the great things about anti-PD-1 therapy in people with HIV. You can really give them any ART regimen. It's not going to interact. I review any potential antiretroviral drug-drug interactions with the cancer therapy, the opportunistic prophylaxis, as well as any of the supportive medications, particularly the antiemetic regimens can interact with certain antiretroviral therapy regimens. It's important to keep that in mind when designing your regimen. And so I think this is a great point that you need to say as an oncologist, you have to be driving the boat, I think, in therapy. You cannot cede all of the HIV care to the HIV specialist. You have to be involved because the HIV specialist doesn't know about your cancer therapy and they don't know about the supportive medications. And so you really have to work together to design the ART and cancer therapy. And I also think it's important, particularly in patients with low CD4 counts, to ensure that all of the symptoms that you are attributing to cancer are in fact due to cancer, not due to other opportunistic infections. So patients who have cancer in the lungs, is there a reason to suspect they also could have concurrent pneumocystis pneumonia, for instance? Do you need to do an induced sputum? Do you need to do a bronchoalveolar lavage to rule that out? And then, unfortunately, all of the opportunistic guidelines are written and useful, but do not take into account cancer therapy. And so I tend to be quite aggressive with prophylaxis for opportunistic infections when I'm treating patients, because I know their CD4 counts are going to drop. I'm definitely going to be immunosuppressing them significantly with chemotherapy or other anti-cancer therapies. And so those thresholds that were developed in the opportunistic infection guidelines may or may not apply to our patients with cancer. So all of this said, there are a lot of things to think about when you're treating patients with HIV and cancer. However, you shouldn't be doing it alone, and you don't need to do it alone. And I certainly don't. I do this with our wonderful multidisciplinary team in the HIV and AIDS malignancy branch, full of physicians, nurses, therapists, social workers, students, patient navigator, pharmacists, working together to care for patients. And lastly, it's really a real privilege to care for people with HIV and cancer. And I think it's been a wonderful career that I've started on so far, and I can't really picture myself doing anything else currently. And so I hope that, I know there's some trainees probably on the meeting today. And so I think treating people with HIV and cancer is certainly a really fulfilling an exciting career, and I've met the most amazing patients and coworkers. And so if you're interested, I'm always excited to talk about it with trainees or students. So with that, thank you very much. And I will hand the floor back to the MedNews team.
Thank you so much, Dr. Lurain, for that wonderful presentation. It was extremely enlightening. So it was really great. So I think I'm sure we have a plethora of questions for the Q&A session, but we want to be respectful of your time. So to moderate that, I'd like to pass the mic over to our moderator for today, Jenna.
Actually recognized leader and researcher. Any questions have been submitted, and we will try to answer them all on a timely opportunity. I will turn the mic back over to you, Kathryn, for the first question.
So Doctor, I'll be asking the first question. So my question is, what treatment strategies do you think can be implemented to combat the new VB variant of HIV, considering individuals with this subtype have a viral load that's about 3.5 to 5.5 times higher?
You are asking the wrong person. You should definitely talk with an HIV specialist about that. I definitely know a lot about HIV care, but I definitely do not know enough about that to comment intelligently. So sorry.
All right, no issues. I'd like to pass the mic back to Jenna for the next question.
Thank you so much, Doctor, for the wonderful presentation. Honestly, it was really interesting to learn so much on HIV and its impact on cancer as well. So my question is, I recently read that we're starting to see patients or people who are living with HIV who have a sustained viral suppression as well as non-severe immune deficiency. Hodgkin's lymphoma seems to be far more common. And this was mentioned as it could be due to age-adjusted or increased introduction of the antiretroviral medication itself. Could you explain a little bit more about this and the trend that's happening?
Mm-hmm. So the incidence, unlike many cancers associated with HIV, the incidence of Hodgkin lymphoma is increasing. Unclear why, but there are several interesting things. The median age of people who develop Hodgkin lymphoma among people living with HIV is higher than it is in the general population. And there's also this interesting phenomenon where people with HIV start antiretroviral therapy. It's in those very few months following the initiation of antiretroviral therapy where Hodgkin lymphoma develops. It's not across the board, everyone, but there is definitely this association. And it may be due to the fact that we know that there is quite an immune infiltrate, an immune environment surrounding the malignant Reed-Sternberg cells and Hodgkin lymphoma. And there may be something having to do, there's likely something to do with the fact that HIV is that suppression. There may be some type of immune reconstitution and reactivation that actually unleashes that control of the Reed-Sternberg cells. And so unclear, but certainly HIV control is not going to decrease the risk of Hodgkin lymphoma in people with HIV. Yes.
Thank you, Doctor, for explaining that as well. Over to you, Jenna.
Thank you. And for the next, you pass the mic to Dr. Lurain.
Thank you so much for that riveting presentation. It truly highlighted the complexity of the field, and in many ways also opens up lots of avenues for research and development on the lines of therapies. Personally, I have a background in research in lymphomas, and throughout the past, I would say 10 years or so, given the advent of immunotherapies, we've seen tremendous impact, tremendous improvement, and just so many new therapies available to patients. Although a lot of these therapies are presently excluded, due to individuals who have HIV, what is your take on the paradigm of cell therapies? And do you feel if clinical trials in that subpopulation were expanded, do you feel we could have similar positive outcomes as we do in diseases like DLBCL and things to that effect? Thank you.
Yeah. So people with HIV are always stuck in this catch-22, right? They're stuck with, okay, well, we don't want to risk our new brand fancy medication, like our new, antibody drug conjugate, or we don't want to risk our new cell therapy. So we're going to exclude people with HIV from that therapy. And then, so the trial's run, and then the trial's over and there's no data. And so then oncologists are like, well, we can't use it now because there's no data. But I will say that, we don't do trials in every single type of patient with every different comorbidity, right? And in fact, most of our trials are done in patients who are much fitter and much younger than the general population of people who have those cancers. And so why we have to make this big deal about people with HIV being this like very, very different subset of patients where we have to extra prove that there can be efficacy and safety in this group of patients. They probably should just be treated like every other group of patients. And once there's a trial and there's a medication approved and they have that cancer, give that therapy. Now, on the other hand, I will say that with cellular therapy, there are some interesting thoughts. So with CAR T-cell therapy, for instance, there have been people with HIV who have received CAR therapy, and the AIDS Malignancy Consortium looked at patients from the CIBMTR and presented data at ASH last year, showing that there are patients who had, I think it was about 40 patients who had received Bcell, and there had been no safety signals identified, and it looked like it was efficacious. And so I think probably people with HIV can get CAR therapy, and there's probably not going to be a huge amount of issues with that. However, someone should probably run a trial, and the AIDS Malignancy Consortium, as well as our branch, are also looking into starting CAR therapy trials. There are certain things about manufacturing CARs that make it interesting in people with HIV, for instance. So when you take cells out of a patient, you're going to be taking some very minor portion of those cells will be infected with HIV. Even in patients who have very well controlled HIV, there are going to be some T cells that you will apherese out of a patient that will be infected. And if you give them, IL-2 or whatever stimulation you're going to give them after you, put in your vector, and they're not in the presence of antiretroviral therapy, some HIV infection probably will grow out. And so it's unclear how much, it's unclear how that will affect cells. It probably won't infect patients when you reinfuse a product because they'll be on antiretroviral therapy. But I think these are the sorts of things that would be very interesting to study, and we will be doing. I also think another, that retrospective paper that we did where we looked at the CD4 count among patients with and without HIV who were on PD-1 trials, and we didn't see a difference. And I think that really goes back to the fact that people with metastatic cancer or people with refractory or relapsed lymphoma, they have very low CD4 counts. And these patients and their T cells are not normal. After you get lots of chemotherapy, your T cells are not the same as beforehand. And so I think the fact that people with HIV would be so different than people without HIV who had metastatic or multiply treated cancer is just not true. I also think that people with HIV and cancer tend to be younger. So they may actually have better organ function than some of the older patients who develop lymphoma, certainly. And so may they actually do better with more aggressive therapy and some of these cellular therapies that have a significant number of side effects? Maybe. That was a long-winded answer. Sorry.
Thank you so much. Really appreciate the thoroughness of your response.
I will be passing the mic over to Alexandra.
Thank you so much, Dr. Lurain, for your wonderful talk and presentation. This was really insightful. My question for you is, what are you?
I'm sorry, I'm not hearing anything.
I apologize, just a second.
Is what are you most looking forward to in the future of infectious disease and HIV?
What am I most looking forward to studying or
Future
or
infectious diseases and HIV.
Sure. Well, in infectious diseases and HIV or in, okay.
Yes.
So so I get really excited about viruses, and I get really excited about diagnosing patients with multiple different infections or cancers and treating patients with very complex medical situations. That actually gets me very excited. And so I'm very excited about the potential for some of these newer, for our patients in particular, some of these injectables, the long-acting HIV therapies, those are exciting. I think the more patients with hepatitis C need to get treated. I think that's exciting, expanding access to hep C drugs. And then those are, and I'm not an infectious disease doctor, but I do think just sort of the awareness of some of the older sexually transmitted infections like syphilis, gonorrhea, and chlamydia that are having more and more resistance to our antibiotics that we have. This is something that's studied by the new director of the National Institute of Allergy and Infectious Disease, who's a really amazing woman, and I'm excited for her to sort of bring that awareness to the field and the development of new drugs and these sort of some of these neglected sexually transmitted infections. I think that'll be interesting as well.
Thank you, Dr.
Wonderful. So the next question, I'll be passing the mic to Helena.
Hi, Dr. Lurain, thank you for the great presentation. So my question for you is, as a mentor yourself, how have mentorships helped you in your career? And what advice do you pass on to your mentees?
So I've had some exceptional mentorship throughout my career. And I think the biggest thing that I've learned is that you shouldn't just have one mentor, and one mentor really can't do everything and give you everything that you need throughout your career. And it's really great to have sort of a mentorship network. I trained at the National Cancer Institute, and I had an amazing mentor, Tom Aldrich, who is an expert in viral oncology, who really helped launch my career when I was a fellow. But he left the NCI when I was a third-year fellow. And I didn't really have any other mentors at the time. And so I think I was able to develop other mentors over time, but I was really I was very shocked and sort of left very concerned about things for a while because I didn't have any other mentors sort of lined up there to help me right away. And so my big advice would be to have, mentors that help you with your research projects, people who can advise you on your career, people who you think are very similar to you and think similar to you, but also people who might be a little bit different from you and can give you different types of advice. I always tell my mentees that it's good to get a lot of advice from a lot of different types of people, but because a lot of the advice will not actually apply to you. And I tell them not everything that I say to you and I advise you is going to be the best advice, and that you can actually tell what's good advice for you by getting different opinions from different people. And so I think it's important just to have a group of people that you can rely on for different aspects of your career. And, people also often ask me, why do you mentor? What are you getting out of mentorship by mentoring all these people if, you're spending a lot of time doing it? Well, if someone's worth being your mentor, they are someone who enjoys mentoring. And it's very, very fulfilling to see your mentees do well and succeed, and to really pay it back to trainees when, I myself have been the recipient of excellent mentorship. So mentorship is definitely something that I really enjoy. And my role in the fellowship at the National Institute of Health is one of the most important and fulfilling aspects of my job.
Hello, everyone. Thank you, Dr. Lurain, for your amazing show. And I have a question about your opinion about the long-acting cabotegravir and the Recipient for the maintenance of HIV, comparing with the standard oral therapy. And I'd like also to know about you if you think that changing this therapy would help to reduce development of complications or malignancies, as you talked about on the keynote.
So one of the most important thing about HIV therapy is that it's taken. It doesn't matter which regimen it is, they're all equally effective. The only thing that makes them ineffective is when they do not go in your mouth or in your arm, in the case of cabotegravir. So we often talk about how patients have the deficiency of putting the pill in their mouth. And it's your job as a doctor to figure out, along with your team, how to get the pill in their mouth, because that is the only way that things work. I see a lot of people conflate HIV control with CD4 count. And in fact, antiretroviral therapy is to control HIV. The HIV viral load is what it means when you have controlled HIV. Is your HIV undetectable? That has nothing to do with the CD4 count. And those things are correlated. So when you have controlled HIV, we think about your CD4 count should increase. However, in the context of cancer therapy, that's often not the case. And often your CD4 count is not going to increase or may go down with cancer therapy. With cabotegravir, it's really very patient dependent. A lot of patients don't like needles, so they're not going to want to be on an injection. It's an injection in the butt. A lot of patients are not excited when they hear about that, understandably. And also it requires you to go to your healthcare provider, to go to a clinic to receive that. That's not a home injection. So that's something, you have to take time off work maybe to go do that. You have to get transportation to go there. So it's not cabotegravir, even though it's long acting and injectable and we can ensure a patient receives it, the patient still has to get there to clinic and receive that injection. And so I've actually been giving it a lot less than I thought I would, because I see my patients so frequently. And we keep such close tabs on them because they're getting cancer therapy that they actually prefer getting a pill. So I think it's really patient dependent, but there's no reason to think that cabotegravir versus any of the other regimens for HIV, one would be better than the other. If it doesn't interfere with your other medications and you take it, that's all that really matters.
Thank you very much for your answer and your insights. It was really clear. Thank you very much.
For the last question of the session, I'll be asking for more junior attendees like myself just getting into research and medicine. What inspired you to pursue the field of oncology? How has this choice impacted your life? Has it been everything that you had initially anticipated?
So the question, and just make sure I heard it, is that why did I pursue oncology? Is that the question?
Yeah.
Yeah.
So we have a lot of junior attendees who are not in medicine yet. So we wanted to know how you felt about it as well.
Sure. Yeah. So when I went to residency, I wanted to be an infectious disease doctor. I have always liked infectious disease and thought I would, treat people with HIV, or I didn't know yet. I did my master's in public health and global oncology, so I also had a big interest in tropical diseases at the time. And so when I got to residency, I went to medicine, and the reason why I'm a doctor is because I love patients and I love caring for patients and having very close relationships with my patients. And I realized that many infectious disease doctors have shorter term relationships with their patients because we have such great, antibiotic therapy that, maybe a lot of the relationships are quite short. And a lot of the time a lot of infectious disease doctors spend a lot of time consulting on the inpatient services in the hospital, which I definitely didn't enjoy as much as I did as seeing patients in clinic. And so I realized that the job that I wanted and the relationship that I wanted with patients was the relationship that I saw the oncologists have with their patients. And so I started thinking about oncology. And so that ended up being the reason why I went into oncology. I didn't know what kind of oncology I wanted to do. I was very interested in lymphoma because patients could be very, very, very sick, and then you give them chemotherapy and they're better in a few days, and you can cure patients with lymphoma, even when they have advanced stage lymphoma, which I really like. So when I went into fellowship, I thought maybe that's what I would do. And lo and behold, at the National Cancer Institute, there's an entire branch that marries sort of the two things that I'm very interested in, that's infectious disease and cancer. And so that is how I ended up in the field that I'm in. I love the fact that my patients tend to be young. They tend to be very sick when I first meet them. Often they have uncontrolled HIV, many different infections, like I've mentioned, sometimes multiple cancers. And I also like the fact that all of the care that we give at the National Cancer Institute is free. So I'm not part of a really big part of the satisfaction of my job is that I can treat anyone regardless of insurance status, immigration status, socioeconomic status. So that's a really big benefit to working at the National Institute of Health, and I think is one of the most wonderful parts of my job. And so I think one of the reasons why I'm not burned out by patients who are very, very sick with a lot of social needs, who I love dearly and sometimes lose, unfortunately, to cancer, is because I'm able to continue to treat people regardless of all of those factors that I mentioned, and regardless of the fact that a lot of them don't receive a lot of good care before they get to our team. And so I think oncology is a fantastic field if you want to care for patients for long term, if you want to help patients who have very serious, very scary diseases. Cancer is a very scary word to many people, myself included. Getting people through that, helping their families through it as well. It's a great way to meet and help some patients who really have one of the scariest moments in their lives, which I love. So oncology is a great field, and I'm very lucky that I've gotten to work in a niche area of it, helping some amazing patients.
Thank you, Dr. for an amazing talk. Huge thank you to our speaker, Dr. Lurain, for an amazing session. Thank you all for the great questions from our amazing attendees. Please continue to follow MedNews Week on all our platforms and be sure to catch the replay.